And now I'm very happy to introduce Dr. James McCormick. He's professor at the Faculty of Pharmaceutical Science at the University of British Columbia in Canada. He has had, as he says, extensive experience both locally and internationally talking to health professionals and consumers about the rational use of medication, and has presented over 500 seminars on drugs, on drug therapy over the last 30 years. And he is also one of the hosts of a very popular weekly podcast called the Best Science Medicine Podcast. Some of you may know it. And if you don't know that, you might know some of his videos, like the Choosing Wisely one, which I think has really gone viral. We are very happy to have you here with us today. And as you can see from James's background, he and his team of the Peer Initiative have decided to boldly go where no one has gone before and explore strange new guidelines that focus on shared decision making. We're happy to hear about that. And James, the bridge is yours.
Thank you very much. That's a very clever introduction, I must say, especially that last part. So thanks for the invite to talk about some of the stuff that we do with the guidelines in the peer group process. So as far as conflicts of interest, my entire salary comes through the UBC Faculty of Pharmaceutical Sciences. I also do some legal work on occasion and obviously some educational work. I've received no honorarium or research money from the drug industry in the last 30 or so years. And as was mentioned, I do a weekly podcast with a family practice buddy of mine. And we do have a premium podcast subscription model that we use to help fund that process, but most of the podcasts are free. As I mentioned, as Karina mentioned, we've been doing this podcast for many years now. We're getting close to episode 500. And what we try to do is provide evidence in an interesting way. And we came to the conclusion many years ago that, you know, one of the best ways to disseminate information is in putting together well-designed guidelines. So this is the group that has been put together over the last number of years, and we all work very intimately together to develop what we call a whole bunch of simplified guidelines. And they're just a great team, and you literally cannot do it without an incredibly solid team. And like I said, the group that I work with is called Peer, and their website is peerevidence.ca. And we've created a number of different simplified lipid guidelines, but we also do, as I mentioned, a podcast, and we also do create evidence synopses that we develop every couple of weeks. And we've been doing that since 2009. And they're just very brief 300-word synopses of the best available evidence for topics that are really interesting, I think, in primary care. So when you think about guidelines, there's sort of spectrums of decisions that we need. We obviously need guidelines for, I think, immediate life-threatening issues or very technical work like surgery and dispensing. And I would say there's no doubt that we need that. And in fact, I would suggest that, you know, those sort of things should even be policies. You know, if you're doing surgery, how many instruments did you have at the beginning, and did you have the same number at the end? So these are obviously very useful. When it comes to things like symptom treatment, migraines, pneumonia, chronic pain, you know, we definitely need some sort of a guideline, but really we have to realize that each person is an experiment. And what the guideline really needs to help clinicians with is to let them know what has the potential to work and the harm, cost, and convenience around those. And then we also have guidelines for risk factor interventions for preventative type of work, lipids, you know, glucose and hypertension. And I'm not sure if we really need specific guidelines. And I'll talk about that in a minute, but at least not the guidelines that we have right now. And I'm going to sort of explain why that is as we go through this. So I think guidelines would be awesome if they were developed primarily by and definitely for the people that ultimately end up using them. I think that's one of the key things that we should focus on. But at present, right now, we did an evaluation this a number of years ago, saying that primary care representation is often just a token thing, somewhat similar to the patient thing. And only about 20% of people on primary care guidelines are actually primary care people. And it's even less if they're industry sponsored. Guidelines would be awesome if there are credible synopses of the best available evidence presented in a way that clinicians could easily access and interpret. But it's actually interestingly uncommon, relatively. Only a third of guidelines do a systematic review. It would be wonderful if guidelines allowed patient values and preferences to be taken into account. But in my experience in looking at that, when we've done a little bit of research in this, it's typically sort of a 1 to 2 sentence thing that saying we should take values and preferences into account, and then they're usually ignored. And interestingly, I've seen a few guidelines where the values and preferences that are put in there are actually the clinician's values and preferences. And I think they missed the boat when they were talking about, when they were trying to think what you're supposed to do with values and preferences. And we did an evaluation of this, and this is a fair number of years ago, and only 0.1% of words in 5 national guidelines had to do with values and preferences. And I've looked at a few guidelines since then, and it's doubled all the way up to 0.2%. And then minimal conflicts of interest. Oh, I think I got a typo there, but at least 2/3 are guidelines are being developed by groups with a clear potential for important biases. And so we're trying to, for our guidelines, we don't allow any sort of conflicts of interest from a financial perspective to be allowed on our guideline committees. So there's some evidence around what the guidelines have in them and what do they do. This is a systematic review looking at primary care cardiovascular disease guidelines. And they looked at 47 guidelines and looking at, did the guideline discuss benefits or harms? And you can see that the percentages, in my opinion, way too low. All of these numbers should be like 100%. They should be about discussing the benefits in ways that people can understand. They should discuss the harms. They need to talk about all of the medications that are available, all of the lifestyle things that need to be done. But the actual benefits are not being presented in many of these clinical practice guidelines for cardiovascular disease or diabetes and that sort of thing. And interestingly, not a single one of them mentions anything to do with deprescribing. So these guidelines are very, very focused on treatment and not the overall look at how we deal with this. And that's one of the, I think, the problems that comes in when you don't involve primary or enough primary care people to be on guidelines. And I'm sure this is nothing new to anybody who's probably listening to this. We know that many of the evidence of the guidelines are not necessarily based on solid evidence. And this is not a criticism necessarily of the guideline, but it's the fact that we don't always have evidence for every recommendation. But it's really important for people to realize that the vast majority of recommendations are not based on randomized controlled trials. And about half of the recommendations are based on opinion. There's nothing wrong with that, but that tells you that we need to be very explicit in how we think about that, because if it's based on opinion, there are lots of ways of getting that sort of opinion into a guideline, and it can be very influential. And a number of people have also looked at guidelines and to look at their reliability. And I'm not saying that this group has nailed it in assessing how many, what percent of guidelines are considered untrustworthy, but they used a process to look at it, and they said up to 50% can be considered untrustworthy. Now, I don't know if you can really hang your hat on 50%, but it really doesn't matter. If it was 50 or 40 or 30 or 20, that's too many guidelines that are being considered untrustworthy. And then one of the key things that we tend to focus on is that most guidelines that look at it will often focus on the population health. While that's important, it's ultimately the individual person who takes treatment. And so one of the most important outcomes that we think is relevant is when it comes to evidence-based practice is not how many people get put on statins, not how many people get their glucose below a certain number. It's, was a shared decision made? Because these conditions are primarily involved with, that's the key thing. And the reason it is that, and I don't think this is anything new to people listening to this talk, but the number of patients who want to participate in that decision has gone up. But it's also really important to realize that there are an important enough percent of patients who actually are quite happy to have their healthcare provider make the decision for them. So we have to realize that we have to run a spectrum of information to make decisions like that in guidelines. And we all know there's very good evidence that that many of the preferences expressed by clinicians and lay people in the study are at odds with the recommendations and guidelines. So I can't tell you how many people I've spoken to who even the guideline writers go, yeah, that's what we got in the guideline, but I wouldn't do it. And there's also many different perceptions of risks, for example, between patients and the healthcare providers. This is an example of 77% of doctors would recommend a treatment for reducing fracture risk, but only 21% of the patient cohort that they asked would consider treatment justified based on when you present the best available evidence to people. So for all of those reasons, we initially tried to get onto a number of guideline committees or national guideline committees, but it ended up just being a token person on them. And all you felt like was that you were just sort of a dissenter amongst all of the sort of specialists. So we decided to create this group, to create national guidelines, if you will, but national primary care guidelines. And we have a number of principles that we follow, and the ones that we've done so far are listed there on the left-hand side. The guideline principles are, they're written by primary care clinicians with input from the specialists, but it's written primarily by primary care clinicians. We always do a thorough systematic review of the evidence. That's just part of the process. We focus on shared decision making. We often do not have, in fact, we've only done one cardiovascular guideline, but we don't have treatment thresholds, we have discussion thresholds. And when you have discussion thresholds, it fundamentally changes the feel of a guideline. And we always provide decision aids, calculators that give the benefit and harms in absolute terms. And at the bottom of this slide, you can see sort of examples that we create risk calculators and happy face sort of icons to show what the benefits and harms are. And we always provide patient information sheets. And these are all informed by getting patient feedback on when we develop these sheets, and they help and we get patients to help inform what the questions are and answers are that would be required in these sheets. And we feel that these parts are actually the most essential part of the guideline, because those are what can be used on a regular basis. And as an example, we did a lipid guideline, and you may have noticed that all of our guidelines have the word simplified in them, because that's what we really need. Our Canadian diabetes guideline is 320 pages. That is way too long, and no one is going to slog their way through this. Most of our guidelines, I think, they top out at 10 pages, I think. So this is we have some flow charts of how people could think about it, and as I mentioned before, there are thresholds for discussion, not thresholds for treatment. And we create patient handouts for that sort of material. And basically, it says, our statins right for you? You decide. This is for the patient. Speak with your healthcare provider. Regardless of your decision, your healthcare provider will support you. And that's a really important process. And it fundamentally changes how we write and develop the guidelines. And it was nice to get some feedback. We got some feedback early on from the BMJ, who did an overview of making evidence work for individual patients, and they appreciated our attempt to do this. And what they really liked was there was sort of offering lifestyle and drug options without judging, and using attractive risk calculators to try and create that sort of an information. And so I really think that guidelines, if you need to go in and focus and say, clinicians need to be able to give ballpark estimates of what happens if you don't treat, or if you don't test, or if you don't screen. And then if you were to treat, or were to test, or were to screen, what are the benefits? What are the estimates of all of these things? And so we spend an awful lot of time trying to make tools and trying to answer the questions that are associated with if you do or if you don't treat. Many of you know the GRADE guideline group that I think has done exceedingly great work in trying to put together a process for developing guidelines. But one of the biggest weaknesses, in my opinion, of their guideline is that they are still continuing to use a strong and weak recommendation. And one of the problems with using words like a strong and weak recommendations is it very much influences the group dynamic of, well, we've got to make sure this is a strong recommendation, or this is a weak recommendation. And one of the problems is even the definitions of these are almost nonsensical. I don't know if you can quite read it, but it says A strong recommendation would be if most individuals in the situation would want the recommended course of action, whereas a weak recommendation is the majority of individuals would want that, but I think but many would not. The problem with that is the words of what most, majority, and many even mean. And for instance, most means more than half. So most is part of a strong recommendation. The majority means more than half, but that's a weak recommendation. So they're the words mean exactly the same thing, but they're linked to either strong or weak recommendation. And then many is a large but indefinite number, but also the majority. So how can you have the majority of wanting it, but many would not? And it's sort of a nonsensical circular argument that you can make. And for that reason, we use the process of looking at the evidence the way Gray does, but we have gone away from using strong and weak recommendations because they, in our opinion, are just very, very frustrating and don't make any sense because of this, the wording of the most, majority, and many. And then most is more than many. So it's really tricky. So one of the things that, the way I think that we should be doing this, we could pretty much split things into two different types of recommendations. If it was a universal recommendation, something that almost 100% of people would choose, whether it be, I don't know, CPR or ICU, the use of pressors in ICUs or sedation or whatever, where a patient's values and preferences may not be needed or may not be possible, we can make it, it's a universal recommendation. You should do this. But then I think, and I don't think this applies to every guideline or every disease that we could do this, but we should be doing, our recommendations should be a shared decision recommendation. And what we need to do is create a guideline that allows for that to happen. And when you realize that you're creating a guideline to do shared decisions, you fundamentally change what you produce. And if you go with that route, I think that's the way guidelines should be put together. And that's why we do them the way we do them. And one of the things to encourage people to suggest why this is an important thing is, and we often when I'm teaching about guidelines to a variety of people, we always hear, well, what happens if you don't follow the guideline? And I think, you know, a lot of people worry about the legal requirements of not following guidelines and so on. But, and there is no great answer, and I can see this slide didn't come quite the way I wanted to do, but those arrows are supposed to be behind these things. But there's no great evidence to say here's what are the legal issues associated with following and not following guidelines. But a number of legal people have looked at this and said, what's the best way to reduce the risk of any sort of medical legal issues around it? And their quite a clear message is that a defensive medicine model where you basically follow guidelines and, you know, treat to standards of care and so on, that is useful, but it never gets you to a low risk of litigation. Whereas if you do a shared decision-making model, so if you do a defensive model, like following guidelines that say you should get cholesterol to be this, your glucose to be this, and you should be on these medications, you never get to a low litigation risk. However, the way to get to the lowest one, and one of the reasons, we don't do it for legal reasons, but I think it's a legitimate additional reason, is that if you do a shared decision-making model where you use a decision aid and you document that decision, that's when you get to the lowest risk of litigation. So there's oodles of advantages for doing sort of a simplified shared decision approach to guidelines. So I think the future of primary care guidelines, I think the majority of contributors should be primary care clinicians. And at least with what we do, we clearly report, we have clearly reported conflicts of interest with targets of 0 or very minimal. And in fact, right now, I think we're at the stage where we have no financial conflicts of interest at all on our guidelines. The evidence review is performed by those with expertise in evidence review. They're not being performed by people who are the specialists in that area, unless they also happen to be experts in evidence review. And the focus is on patient-oriented outcomes with an emphasis on shared decision-making and minimal disruption to the patient's life. We take into account that in an important way, because a lot of the I mean, if you right now, if you had patients follow all of the chronic disease state management guidelines, they would be on a huge number of medications. And we often forget to realize that there is a financial burden and a convenience burden that we put onto people for that. And then finally, we title our guidelines, this simplified guideline of whatever, is that simplicity is the overriding goal. And the reason is we realize that it needs to be simplified, not because people can't follow more difficult things, but they need to be able to use that information in a simple way and be able to explain it to healthcare to their patients about what the benefits and the harms are. And I think this is a quote from a colleague friend of mine who said, "I'd rather know evidence and try to apply it to each patient than memorize guidelines and try to apply them to all patients." And I think that's a really important focus. And at the end of the day, when it comes to guidelines, we've all got to the point we sort of a bit of a tongue-in-cheek comment about our panel. We said, we're the panel who doesn't care. We don't care. We don't care what the guideline finally recommends. We just care that it's put together in a way that's understandable. I can't tell you, as an example, for our lipid guidelines, none of us really care if a patient takes a statin or not. We care that they've been informed about it and they've made a shared decision about it. And so that's sort of the overall approach that we take to guidelines and the development of guidelines. It's all about being simplified, and it's all focused on shared decision making. And I think I'll leave it at that.
Yes, thank you very much. That was really refreshing, as someone says in his comment and question. And I definitely start to read out those that I got here. Hannah Lange asks, thank you for a refreshing presentation. Could you expand on your earlier comment about the usefulness of various types of guidelines? This is referring to the slide about surgery, saying yes. So I mean that the question might be about the indication for surgery or how to perform the surgery. Maybe that.
Yeah, no, it wasn't really about surgery. It was about the point of so the guidelines that we developed were all about shared decision making. We don't care about if people take it. However, there are things that we have to have very specific guidelines, or maybe even protocols for things that are very technical. So we need, if we're going to do a guideline on dispensing of medication, or if you do a guideline on surgical care, some of these things are very like I'll give you a good example. We want our pilots to follow very specific checklists, and they should do it every time because it's a very specific thing that they need to do. But we don't need healthcare guidelines for the vast majority of things to be that prescriptive, if you will. But they are very prescriptive. That, your blood pressure needs to be this, your cholesterol needs to be this, you should do this with this medication, you should do that with that medication, you should choose this one first. That's what we're trying to get away from. So that was the point I was trying to make. So we do need, in some circumstances, a very specific thing that you must do this, but for the vast majority of things, we don't need that.
All right. And the second question is, can you speak to the implementation of the peer simplified guidelines? Is implementation also simplified, and have you or others studied this?
Yeah, so I don't have the details of how many people are using them. We have those, I just don't have them off the top of my head, but we disseminate all of these guidelines in the Canadian Family Physician, which is the national sort of primary care journal. And it goes out to them, and then they're all available, free to everybody on a website. And all of our things, like our tools of practice that I mentioned earlier on, we have I think we send those out to 40,000 people every couple of weeks. We disseminate them as widely as we can. We do talks all the time on this sort of information. I'm trying to think. Oh, as I said, we do a weekly podcast where we talk about the development of guidelines, but not just guidelines, but we talk about the development of them. We talk about how to think about evidence and all that sort of stuff. So yeah, I think it's really important to have a sort of a dissemination approach to it. And we keep some statistics on it. I just don't have any of those at my fingertips.
Thank you. And one last question from Sarah Twaddle was, how do you attract primary care clinicians to be involved? UK experience that this is very, very difficult.
Yeah, so the way that this came about was there was a core group of probably 4 or 5 primary care clinicians who were academic primary care clinicians, and they were very, I would say frustrated is a bit of an under exaggeration with the guideline development we have so far. And all of us have been asked to participate in guidelines, in national and international guidelines. We found the process just not of value at all, because it was literally being taken as a token involvement. And like, you'd be put on a lipid guideline, and you could say, well, you could challenge to say, well, does everyone really need to be on a statin? And they do, well, of course they do. And then you'd have 15 specialists who agree with everybody. And I think many of the people who are probably listening know that if you want to know what's going to be on a guideline, just find out who's on it. And then that'll tell you what they're going to say on the guideline. And so we started slowly, and if you go back and look at the list of the people who are on there, these are all primary care clinicians. And I can't tell you how much fun and enjoyment we have. And we can get people on these guidelines because they're passionate about this whole process. But I can tell you right now, not one of those people in peerevidence.ca would sit on a national guideline as the token healthcare provider, because the guidelines are not, in general, they're not being done the way that we think they should be done. So I think if you're trying to just get token people on them, many of these people here have their academic careers are based on that, but we actually have the more primary care clinicians you put on it, the more access you have to more primary care clinicians, because they know more people, and it sort of just mushrooms out of it when you have primary care clinicians being responsible for it, not being asked for their input.
Okay, I see loads of more questions here, but we won't be able to answer them right now. We'll keep them for the final discussion if we have the time. Thank you so much so far. From all the questions that I see here, I can understand that people found it a very inspiring talk, and they thank you very much. And I pass over to Joseph and our third speaker.